I'd like to welcome everybody. Those of you who are tuning in, thank you very much for spending your Tuesday night with us. As you know, and as of those of you who have seen, my name is Eric Wagner, and I'm lucky to be joined with Chris Clifto, who's going to be helping to moderate this, as well as Grant Garrigus. We are honored to have an international panel of experts on this year's or this month's topic. So, as you know, we're talking about shoulder. Do you mean to stop that, Steve? So, and I don't think we could be better graced by two of the sort of world experts, and really don't need a lot of introduction with John J.P. Warner and Dr. Matt Provencher, two just thought leaders and really kind of push this field forward. We also are lucky to be graced by the authors as well as experts in their own rights. From Germany, Phillip Morrider is staying up 2 in the morning, going to be 3 in the morning by the time he tunes out. So those of you who are tired, you can imagine what he and his resident Eva Schultz are feeling, as well as Peter Lappner and Peter McDonald continuing to sort of really push the field forward with some of their just excellent innovation in many aspects in shoulder surgery. And we really appreciate you guys joining in and sort of contributing to this kind of fun, exciting event. So without further ado, I do want to sort of thank our sponsors. Steve, go ahead and maybe play this video. Wonderful, thank you, and thank you to Stryker /28 and Wright, and thank you to Zimmer Biomet for sponsoring this. Chris, do you have anything you want to say before you want to get us started on the first article?
Yeah, absolutely. So just like last time, send your messages to the Q&A session for the chat session, and we'd be happy to get them to the expert panelists. And I think otherwise, let's have some fun. All right. So the first article is the arthroscopic Bankart repair with and without arthroscopic infraspinatus remplissage and anterior shoulder instability with a Hill-Sachs defect, a randomized controlled trial. All right, so this was a multi-center, double-blinded, randomized controlled trial comparing a Bankart alone versus a Bankart remplissage for patients with anterior instability and engaging Hill-Sachs. Had 108 patients in the study over a 6-year period, 54 with no remplissage and 54 with. Inclusion was patient over 14 years, recurrent anterior instability, gauging Hill-Sachs of any size. Exclusion was greater than 50% glenoid bone loss, MDI, laxity, OA, and prior surgery or infection. So the technique was mostly lateral 2 anchors, tied with sutures for the remplissage, and 3 anchors for the Bankart repair. There were similar demographics and follow-ups between both groups. There was no difference in the PROMIS or PROs rather, or shoulder function at greater 2 years post-op. And there was no difference in final external rotation between the groups. The recurrence rate was higher in the no remplissage group, which was 18% in the no remplissage and 4% in the remplissage group. The reoperations consisted of 6 in the no remplissage group and 8 in the remplissage group. There was a higher redislocation rate if a Hill-Sachs was greater than 20 millimeters in width or greater than 15% of the humeral head diameter, which was 22% in the no remplissage group and 2% in the remplissage group. So this was a great study that concluded and helped support that remplissage for patients with an engaging Hill-Sachs lesions. It helped confirm other clinical studies and add to the threshold of greater than 20 millimeters and greater than 50% humeral head diameter is worth doing a remplissage. Dr. Lappner and Dr. McDonald, what did you learn about treating recurrent anterior instability after leading the study? And what were some takeaways not conveyed in the study that you would like to talk with the panelists and the participants of this journal club?
Go ahead, Peter.
Sure, thanks. So thanks, Chris. That was a great summary. Pete McDonald led this study, so we'll give him the final word. But to answer your question, so first to determine whether or not the results of the study were valid, if we apply the Cochrane risk of bias tool, we see that the allocation was random, allocation was concealed, participants and assessors were blind, and there was little attrition and no selective reporting. So I think a lot of strengths to the study so far. The groups were similar at baseline, so randomization, I think, was effective at balancing the groups in terms of the various confounders, and they were also treated very similarly, other than the one intervention that we were testing. So I think taken together, I think we can say with a fair bit of confidence that results were valid in the study. So when we look at the results, we see that, as you mentioned, Chris, the function was similar. There was a 10-degree difference in range and abduction external rotation in favor of the no remplissage group. But the most interesting finding, as you pointed out, was the difference in the incidence of recurrent instability. So in order to interpret that, and in order to really get a handle on the strength of the treatment effect, the p-value maybe not so helpful in this situation. We can look at the confidence interval as a measure of precision, but I think it's nice to apply the fragility index in a case like this, which is the number of non-events that would have to be converted to events in the treatment group to render that p-value non-significant. And the fragility index in this study for that finding in terms of the recurrence of instability was 1, meaning that if we had one additional dislocation in the remplissage group, that would have rendered that p-value non-significant. Now, what's interesting is that if you apply that p-value to the higher risk group, the group with the wider Hill-Sachs lesion, the fragility index increases to 2, which I think increases the confidence in the findings. So what does this mean? I think, number one, that remplissage does have a role to play in the treatment of recurrent anterior shoulder instability. And 2, that I think that we need further study really to further define the indications in terms of which population exactly would benefit the most, and in order to increase the confidence in the study findings. So I'm interested in Pete McDonald's thoughts.
Yeah, I mean, that's a great summary. I can't add much to that. There's a lot of hesitation with remplissage. When you see it talked about at meetings, people would say, well, you know, there's a high incidence of posterior superior shoulder pain. There's a definite decrease in range of motion that you have to deal with. It's not such a good operation. You should go to a Latarjet. So I think after this study, we have a little more confidence in doing a remplissage procedure within limits, within a certain degree of bone loss, without some of the adverse effects that we're afraid of. And that's been borne out by some other studies as well. Yeah, no, I mean, that's fantastic. And you're right. That's a subtle finding that the impact on motion that maybe doesn't always get conveyed, but it has been kind of reinforced by a couple ones since this point. So that's a great point. So, so Dr. McDonald, right now you have a patient that has less than 15% of their humeral head with a Hill-Sachs, you know, less than 20 metatarsals, so not in the high risk group. Are you doing a remplissage on those? Are you doing a Bankart alone? How are you making that decision? Yeah, it's a good question. As you know, like the Hill-Sachs lesion, you can't just go by, you know, the percentage. There's a lot of factors, where it's located on the head, the amount of glenoid bone loss. In this study that we did, we limited the glenoid bone loss obviously to less than 15%. So not to get into critical glenoid bone loss values, which is kind of a different subset of instability. To answer your question, I would kind of do the Bankart repair and then kind of see afterwards what the degree of engagement or how close that Hill-Sachs lesion is to engaging. And if there's any question of it even coming close to engaging, I would do a remplissage. Fantastic. All right, and then Dr. Labner, going on the opposite side. So when is too much? When is it too much to just do a remplissage? When are you now considering some sort of bony augmentation, whether you're talking about Latarjet or something on the humeral side? Yeah, so I mean, that's another great question. I don't really have an upper limit in terms of the absolute size of the Hill-Sachs lesion, at which point I would then necessarily go to the glenoid.
we know from a recent systematic review that was put together by Mo and Khan that, as Pete alluded to, in instances where there's a greater amount of glenoid bone loss, greater than 10%, it looks like although it's based on lower level of evidence studies in general, it would appear that the results of the remplissage procedure begin to taper off above about 10%. So I think probably more interested in the size of the glenoid bone lesion.
Makes sense.
All right, we've got some questions from the audience. So the first one's from Neelan Bendigu from USC. He says, hello, thank you for having this journal club. An engaging Hill-Sachs lesion was determined intraoperatively before Bankart repair in this study. I've learned from some of my attendings that a more accurate assessment is to check if the Hill-Sachs engages after Bankart repair. Doesn't matter when you test whether or not a Hill-Sachs is engaging, i.e. before or after the Bankart repair. Dr. Lapter, Dr. McDonald, Dr. Warner, what do you think about this question?
Well, I think, all Hill-Sachs lesions must have engaged at some point in time or they wouldn't be there, right? So the term engaging Hill-Sachs is kind of a funny term. I tend to, there's different ways of looking at it. You can look at glenoid tract, all that stuff. I tend to do my Bankart repair and look at the degree of engagement after, but I don't really like that term engaging Hill-Sachs because it's kind of a nebulous term, but that's how I do it. There's a lot of different ways of going about this.
Dr. Warren, do you mind addressing that as well and talking about your thoughts on assessing Hill-Sachs preoperatively, intraoperatively, and when do you feel like a remplissage is indicated versus maybe something in addition to just a simple Bankart?
So first of all, let me again congratulate the authors. There's nothing wrong with the methodology, the conception of the art of the study. Everything's perfect. But I have a cognitive bias, and I'll disclose that to begin with. I measure everything I do. I have a registry. I'm very interested in certainly innovating, but having a reliable, reproducible approach. As a general rule, in my experience, the size of the Hill-Sachs lesion is correlated to the number of dislocations and what you see on the glenoid side. It's very rare that you have a huge Hill-Sachs lesion and not much on the glenoid side. And the number of, you worked with me, the number of remplissages we did were how many when you were with me?
Not
right?
many.
So that's my bias. That said, how many recurrences do we have with the Latarjet? And one of the things that I've learned is that you don't engage unless you translate forward. And if you contain the defect on the glenoid, it does not engage. And that's exactly what happens kinematically with a Latarjet. And there's many different ways you can approach it. It doesn't invalidate the approach of doing a remplissage. That's very valid if what you want to do is arthroscopic. But because Latarjet has been so reliable for me, and even now in Europe, there are some wonderful surgeons developing arthroscopic approaches for those who want to stay arthroscopic. That seems to solve the problem for me. And so that's just my cognitive bias. I'm not usually addressing it. And I just want to make one comment, but you were going to ask me a question before, but further down on the list you sent me, but let me get this one out of the way. One of the things I wonder about is the duration of the study is certainly sufficient for publication, but from Gerber's work, we know over time with longer follow-up that patient outcomes can deteriorate, particularly with Bankart repair, and recurrences do happen. And you miss that if you don't go far enough out. He at least made that point with his Latarjet versus Bankart repair. And so that would be a little bit of concern for me here. And the other point I want to make is when you do a Latarjet, these patients, we follow their process of recovery, they move the arm very quickly. When you do a remplissage, what's your postoperative process? And that I think is also relevant to the patient's outcome. So I'm sorry to dance all around this, but I'm really not generally assessing a Hill-Sachs lesion unless there's like a lock dislocation and it's a really big defect that goes along with the glenoid. And that's been relatively rare. And I think in your year with me, I'm not even sure if we saw one. Sorry about all.
Thank you. No, you're perfect. That's awesome. And Dr. Perventure, can you add to this discussion? Can you give us your insight into approaching this Hill-Sachs, your pre-op intraoperative assessment, both with regards to deciding a remplissage or deciding some sort of bony augmentation procedure?
Yeah, thank you. Thanks for setting this up. This is wonderful. Peter, and your co-authors, congratulations. This is a great article. For those that want to do some organized, randomized trials, it's a really nice way to organize it. Putting on my journal editor hat, it's extremely well done. It's of course not perfect, but it's a high-end level 1. It's not even a level 2 randomized, and so congratulations. I just had a few questions that sort of dovetails into this. The Hill-Sachs is highly dependent on the glenoid bone loss. Glenoid bone loss dependent on the Hill-Sachs and vice versa, in chicken or egg, in terms of recurrences and number of times. There is certainly a risk stratification to number of recurrent instability events, and we all know Christian Gerber would say, I don't know what you're doing in the United States. If it dislocates or instability event more than once, it's an open Latarjet for me, and there's nothing else that will work in his hands reliably. So what you've shown here is that the remplissage is pretty compelling, and the number needed to treat and make a difference is also compelling as well. I do like your assessments. The problem with the Hill-Sachs, and I see Ivan Wong's got a question on there too, is the reason we don't extrapolate it as well is we just don't have a great measurement tool for it at this point. And you've done a reasonable job, I think, of doing the percentage and the depth and width and doing a 100% standpoint, and then looking at the glenoid bone loss, which, by the way, I think you had an article, but I assume was a perfect circle technique. I didn't see per se, but they're codependent on each other, as well as certain factors which we've found to be the angle of the Hill-Sachs plus medialization of the Hill-Sachs. So not all Hill-Sachs is created equal, and it's not just a percentage. So this is wonderful. I think it's great, but I also look at the medialization, which also tends to JP's point of being a larger, deeper, more meaningful Hill-Sachs, as well as Hill-Sachs angle, which Giovanni DiGiacomo and I just published on an arthroscopy, looking at the Hill-Sachs angle and the higher risk with a higher angle of Hill-Sachs lesion, not just the depth and percentage. So we still have a lot of work to do to clarify this, but from your patients and how you enrolled them, it was wonderfully done, and certainly gives us some meaningful information. So thank you.
Awesome, thank you. And then kind of round out things, Dr. Morrider, do you want to give us the European perspective? Both JP and Matt and Dr. Provencher gave us their 2 cents on kind of their approach, as well as referencing some of the European perspective. Can you give us your sense to either the German or European perspective of both this topic of remplissage and Hill-Sachs deformities?
Thanks, Eric, first of all, and Chris for inviting me to this beautiful event. I wish we had something similar in Europe, but maybe we're going to copy it. So my personal opinion is that the primary threat for stability is the glenoid bone loss. If you have a glenoid bone loss, you go for a glenoid reconstruction surgery in terms of a Latarjet or free bone graft transfer. And this is in almost all of the cases also gonna put your Hill-Sachs defect back on track, literally. And if you have the rather rare but possible situation of no glenoid bone loss and a large Hill-Sachs defect, I think there's a nice study out of the US that showed us that in collision and contact athletes, you want to go for Latarjet nonetheless. But maybe in sedentary persons, maybe you have like a 40-year-old, not so active gentleman. In these patients, I go for a Bankert and remplissage. And I think the very nice randomized trial by Peter and Peter showed us that there is worth in doing a remplissage in such cases. I just worry a little bit about the rotational deficit that might occur.
Wonderful, awesome. So I think we'll move on to the next article, just kind of to stay on time, if everybody's good with that. And Klepto, feel free to continue to interrupt as we kind of go. So we're going to move on to continuing along the European flavors. So Dr. Morrider's article on Latarjet versus iliac crest bone graft, another really well done randomized control trial comparing these 2 techniques. They use the J bone graft technique that we're going to hear about a little bit later as well. So basically randomized, ultimately 54 patients were included, 29 iliac crests and 25 Latarjets. The inclusion was greater than 2 dislocations and greater than 15% glenoid bone loss. So kind of a nice transition from the last article. Their technique with large J with 2 screws, flush graft with a CA repair to the capsule, while the iliac crest bone graft was an implant-free J graft, an anterior glenoid neck osteotomy, and then a burr to shape the graft. Table 1 shows the similar demographics between the two groups. Should be noted that there's more prior Bankarts and large J group compared to the crest bone graft. Otherwise, there's no difference in the push PROMs, as you can see in figure 2. Figure 3 shows the lower internal rotation for the large J group at every follow-up, 1 vertebral level, or 6 degrees of internal rotation at 90 degrees of abduction. Otherwise, there's no differences in any motion or strength. Post-operative subluxation, there is sort of 1 in the large J group and 2 in the iliac crest bone graft. Really not a big difference. Positive apprehension, 10% in the iliac crest versus 7% in the large J. And in general, the complications were not much. There was some joint site morbidity, about 27% in iliac crest bone graft. Cool. Figure 7, looking at the CT, the glenoid augmentation in iliac crest graft was initially present, but it kind of faded over time. This was kind of a cool assessment that was, I think, that really nice contribution. So overall, great study, level 1 study, contributes wonderfully to this discussion of glenoid bone loss and some of our last kind of follow-up, some of the last discussion we just had. You can see there wasn't big differences, some subtle differences potentially in internal rotation. It's hard to say how clinically relevant those are. And then otherwise, it's kind of a great contribution to this evolving controversy. It kind of adds to Dr. Provencher's prior study on comparing DTA to large J, and some more evolving discussion in the future. So kind of to kick it off, Dr. Morrider, do you want to talk to us, one, when you're deciding on the optimal graft or technique that you're going to use, how do you make this decision? And can you give us some stuff maybe beyond the study, or have you learned since the study that that can kind of teach us? Ladder J tends to be a little bit more familiar in the United States. That being said, distal tibial allograft has become this J technique, I think, is a little bit less familiar. So any kind of insight you can give us from your perspective with regards to the study and takeaways going forward?
Thank you very much for this very nice summary. So I think that the study data showed us that in case of significant glenoid defect and anterior shoulder instability, you can choose both techniques. Both will render similar results, either a lateral J or a free bone graft transfer, whatever graft you're going to use. But the differences probably lie within the complications. So the most complications we saw with the lateral J are more based on the screws, the implants that are used, and in this special technique that we used for the free bone graft transfer, which was the J bone graft, which is a press-fit keel-shaped graft that is impacted into the glenoid without any screws. Obviously, we didn't see these issues. But on the other side, we had some donor side morbidity in terms of sensory disturbances. And so I feel like personally now that if I have a patient with a significant glenoid bone loss, I like to go for implant-free reconstruction of the glenoid. It just gives me great results, and it feels like the anatomical technique is a little bit less invasive. However, I would like to improve on the donor side morbidity. And there is some cases where I do a lateral J, and this is patients with a failed prior Bankart repair, small glenoid bone loss, not large glenoid bone loss, and contact athletes, because we saw in other studies that free bone graft transfer resorbs a little bit more than the lateral J if you augment the glenoid more than the natural shape was or used to be.
That makes sense. And can you, for those of us in the participants that maybe aren't as familiar with this J graft, can you give us a technical pearl too on how to optimally get the fixation, get the press fit correct, shape the graft? Anything that might teach us people a little bit less familiar with how to do it?
Yeah, I learned that when we teach our residents that they are always afraid of doing the osteotomy at the glenoid neck, but this typically is not the biggest issue. You have to keep your distance of about 5 millimeters and have a slight angle towards the articular surface, of course, so that you're not going to perforate or fracture it. But the more critical aspect is the shaping of the iliac crest graft, because this needs to be in a very standardized shape, and not always the iliac crest comes in the same size and shape. So you need to be very careful about creating a perfect shape that's then going to match into your osteotomy. And this is the most tricky aspect of this surgery in my mind.
Wonderful. Perfect. No, thank you very much for that. And Dr. Provencher, I can't help but rope you into this discussion given your recent AJSM publication as well as a lot of your work on this. Can you give us your thoughts on the distal tibial allograft compared to the lateral J, as well as potentially this J-shaped bone graft that Dr. Morrider is and others in Europe have pioneered?
Yeah, Philip, congratulations. I think a great study, and certainly helps us understand what's going on, not only with how these patients are doing post-operatively with some really nice outcome scores, but also some of the CT scans after. Just as an aside, I thought it was interesting that you weren't able to convert everyone. And in fact, a good portion, 20, 30% still were off track despite bone grafting. And so probably taking into account the Hill-Sachs, and I think it's another interesting point of discussion that you're still thinking about converting these folks to purely on track, but they weren't really even close. Maybe they were near track based on your measurements. But when you first published on the J graft, I was always very intrigued by it. I was intrigued that the fixation, especially with the press fit, was good. And I think what you gain there probably in what we studied biomechanically here quite extensively in our lab is that shear resistance of the graft and the ability of that to hold and not obviously have the lateral J conjoint tendon pull. And so when you look at some of these biomechanical studies, you have to be really careful because first of all, these lateral J studies are pulling the conjoint tendon biomechanically at the wrong axis. It's not through a simulated subscap split. And whereas you have this J graft, which doesn't really depend on, a free graft, a la tibia, J graft, et cetera, does not depend on the conjoint tendon coming into play and potentially adding in some level of complications, although we do know from Yamamoto's work in about 2010 or so that this actually does add some sling effect, if you will, to the overall construct. So I think the free graft versus lateral J debate will continue, and I think this certainly adds some fuel to that fire. So thank you.
Dr. Warren, can I rope you in then as a somebody who I personally learned lateral J from, and who's really kind of taught us a lot about both the how to do a lateral J as well as the complications associated with it, with your own near award-winning trial and subsequent follow-up studies. Can you give us your sense on this growing debate and some of the different options and how you make the decision?
I find it interesting when we're debating because we all have, as I said before, cognitive biases. And so again, these are groups that, let me just say, are both very successful as forms of treatment. My own personal experience has been with bone graft reconstruction of the glenoid, which we published in AJSM, I don't even know, 15, 20 years ago. That was the best group for instability patients I ever had. I had 0 failures, and all the professional athletes went back and played. In those days, we used the row score. They were like 100. And these were people that had hundreds of dislocations. So that's an incredibly good operation. Whether you want to do a distal tibial allograft, which is now, Matt's baby here, which will eliminate the morbidity that you guys recognized from the donor site, presuming that that's got the same incorporation and less, and the same resorption. That's just great. That works terrific. There's many different ways to do these things. Me personally, I think that the J graft is, from what I understand, is a very precise technique to do. You talked about that. It's not a margin of error kind of a thing. My main experience with it is posteriorly. And I think it can be rather difficult to replicate what the experts can do. Lateral J is not the easiest thing to do, but it's pretty straightforward. And one of the questions you asked me, Eric, is when is it too much bone loss for a lateral J? Which, if anybody knows the literature that can tell me that, I'd love to know it. But one of the things is, as you lose bone, several things happen. One, you have less bone to fix your lateral J to, and so the strength of the fixation is a bit problematic. And two, you medialize the bone graft and create a significant sling over the axillary and muscocutaneous nerves. And it's not proved, but it's my impression that that also can be associated with a greater incidence of neuropraxia, just because of that huge sling effect, particularly in very muscular people. And it's a qualitative decision that I make, but when there's significant bone loss, whatever you want to call significant, we could debate. There's no way in the world I do a lateral J, I do a bone graft that works terrific, okay? But when there's not, then I do a lateral J. And I'm not really worried about which I'm going to do because the reliability is just so good. And thank you for bringing up my experience with Latarjet. I'm known for all the complications I had, and I just want to make sure everybody knows that my JBJS article is just an insight into learning curve. That's it, okay? If you're like Jill Walsh and you can do this in your sleep with one hand behind your back, you just don't have complications. So it's very hard to sort out what experts can really do, because when they're experts, they can do almost anything really well.
JP, your article in AJSM, which I think is about 2005 or 6, is one I've gone back to many times and has taught us so much. I think there were about 11 patients or so, but talk about a very impactful article with a small number of patients. There was only one other article that I'm aware of in the literature that was actually published in Military Medicine that had maybe 14 or 15, but you're talking about 25 patients in 2005 with iliac crest, and look where we've come in the last 16 years. It's pretty amazing. So JP, thanks for pushing the envelope with that. And it's good to hear, your great results, which is clearly shown on AJSM. And that's why those free graphs, I think, continue to be compelling. And like JP said, I think a really nice augment to our treatment armamentarium.
Awesome. So Dr. Preventer, kind of continue on that. Is there, do you ever consider bipolar bone grafts? Is it ever so much that you're going to go after it, especially in some of these really young contact athletes?
Yeah, we're getting more and more into the three-dimensional modeling and what we can reconstruct. If we can truly make this an on-track versus off-track lesion, there's more to it than that. There's the Hill-Sachs angle, there's the medialization of the Hill-Sachs. I think there's some other things that go to it, but you can certainly, and I think as Peter alluded, and also JP, if you're putting in too big of a graft, that's a problem. It's a problem for the subscap. It's a problem with other things. Or if you're posteriorizing that Latarjet with musculocutaneous, I've had that happen. It's a real issue. It's not fun to deal with at all. Fortunately, came back at 6 weeks, but I pushed the envelope too much, even with the articular arc rotated Latarjet with a very big bone graft loss. So then I go back to JP's technique with the iliac crest or distal tibia. So I do bipolar, not very frequently, but ones that I am concerned that I can't get a conversion to a reasonable on-track or a near-track lesion when we're doing some of these measurements. And those are the ones that I spend a little bit more time measuring after work or in clinic, et cetera.
And I don't know why they've been in this discussion, but I just got texted by a friend, and Dr. Preventer, or maybe Phillip or Dr. Whoever wants to take this. One of them asked me, so one of the advantages they think from a technical standpoint of here I'll read it, of a Latarjet is that you take the conjoint down, and so it makes it easier to get your angle for the screws. Can one of the panelists please give us a technical pearl about getting your angles when the conjoint is intact? I don't know who wants to take that, but if somebody wants to take that. Dr. Preventer, do you want to take that, or Philippe, do you want to? I guess since Philippe does implant this, Dr. Preventer, do you mind taking that?
Sure, Eric. Yeah, it can be tricky. So first of all, patient selection. If you have a huge NFL lineman and you're doing a free graft, it's probably going to be a Latarjet for me because of that. The deltoid, the delta pectoral interval, that's going to be a challenge to manage. Any way you slice it, and that conjoint is going to be massive. So patient selection out the gate is important. Second is just gentle retraction, good freeing up. Third is patient positioning, scapular positioning on the table. JP taught me this, actually bringing the patient down a little bit further, and so that the scapular gravity is a little bit better, and you've got that shoulder externally rotated. And then arm position is critical. I use generally a padded Mayo stand, so I can control the arm much freer and a little bit easier for me. And in my hands, I can get better trajectory for that. And if you look at LaFosse's work and his learning curve of the 100 arthroscopic Latarjets, he clearly showed that over 15 degrees screw angle relative to the glenoid surface. So it was more than 15 degrees relative to the glenoid surface. This is arthroscopic, where you're taking it down doing Latarjet. He had a much higher complication rate or other issues with it. And so that was a big learning curve. And so I try to be within 15 degrees of the glenoid surface. We don't always get there, especially in these big patients, but that's where I try to be.
I have a question along those lines from Aaron Underher. Said, would you consider a Latarjet more suitable for contact athletes than iliac crest bone graft in terms of strength of the construct and time to resume to support activities?
Can I just comment here? Just bridge to that and just a comment about the patient Matt talked about. If you look at LaFosse's approach with Latarjet, he literally makes a portal through the pectoralis to get the right angle. And then think about that when you're doing it open and how hard it is to get that kind of an angle. But some things you can do is the way you move the arm, you can rotate the scapula sufficiently to be able to get a good view. You have to be aware that you have to retract sufficiently to do that. It can be quite difficult in people with large muscles. By the same token, if you do a bone graft reconstruction and you remove the subscapularis, it's much easier to expose the glenoid rim, and you also are moving the neurovascular structure somewhat out of your way. That, however, introduces the risk to the subscapularis when you do a repair. And I think it was Gerber who said some time ago about mini open versus arthroscopic rotator cuff repair or open rotator cuff repair, that if you split a muscle and pull real hard on it, you get hamburger. But if you carefully take it off and put it back, you get filet. And so you want to be careful in thinking about the really big people. Make sure you take the time to do a good approach, to think about how you take tension off the neurovascular structures and do the operation right. Don't be constrained by splitting giant muscles and getting deeper and deeper in a hole and then hoping that the screw has the right angle. And when you look at the worst ladder J's ever, the screw is always going away from the glenoid. And it's too lateral, okay? And the bone graft is too lateral, and they're going that way because they can't get their hand medially.
The other point for the same patient, if I may add something else, is that taking down the conjoint tendon is not a sin. So if someone is in the operating room and realizes that you just cannot get there, it is okay to take the conjoint tendon down, do your grafting, and then resuture it again. If I remember correctly, Carter Rowe described the Bankart procedure taking down the conjoint tendon. And then secondly, going to Laforce's comment, you can do a percutaneous portal for your screw trajectory in the very large patient, as long as you're very careful dissecting between the pectoralis minor and the conjoint to avoid the brachial plexus. That's another trick that I have used occasionally, just for the screw trajectory, not for the grafting. You place the graft through the usual exposure, and then you can come almost percutaneously to get your trajectory right in the very, very large patient. So those two things may help the audience as well.
That's awesome. Thank you. Thank you for joining us, Joaquin. Philippe, before we go on to the next one, do you want to give us any last your 2 cents or any last comments about this topic or this article?
Yes, just a quick comment. There's been a very nice study coming out of France from Lionel Netton, who showed us that even though in arthroscopic latargés you use a Far East portal, the screws on average have an angulation that is far worse than with the open technique. And this can only be improved if you use a different fixation technique that's drilling from the posterior side. So, for example, button techniques. So it feels like with the open technique, we are able to push the neurovascular structures and so on towards medial. And even though we approach from the Far East with the arthroscopic approach, still the screws end up to be more angled than with the open approach.
Amazing, awesome. Why don't we go on to the next one? So the next one's staying with our European theme. So Dr. Gerber and Dr. Weiser's a posterior glenoid osteotomy for glenoid retroversion, a case series of 7 shoulders that were done, 15 years of follow-up with a minimum of 10 years. Inclusion was retroversion greater than 15 degrees. So patient characteristics, the mean retroversion was 20 degrees, so pretty retroverted. The technique was a after posterior deltoid reflection and going between the teres minor and infrastinatus. They did a opening wedge osteotomy with the iliac crest bone graft impact in there, not the J graft, but just a bone graft. Ultimately, when you look at their outcomes, they had a 86% recurrence rate in posterior shoulder instability. Mean time recurrence, interesting enough, was 6 years, so not immediately, kind of hinting at Dr. Warner's point earlier about the importance of long-term follow-up. There was one revision that was performed. Overall, no difference between preoperative and postoperative pain scores. And in general, they were worse if the patient was, humeral head was posterior subluxed postoperatively, as you can imagine. In general, retroversion was able to be corrected, but preoperative posterior subluxation was not corrected on post-op CTs. So a great study, long-term follow-up at the case series, but still long-term follow-up of a of a very difficult patient population, emphasizes the importance of long-term follow-up when you're dealing with these instability patients and instability articles. And interesting enough, they've had a more recent article on the J-shaped opening wedge osteotomy technique, showing promising techniques, promising outcomes at 2 years. Once again, relatively short follow-up. And I'm going to read a couple of Carl Weiser. He apologizes for not being able to be here, but I'm going to read a couple of his comments real quick, and then we're going to kind of open up this discussion. So he said, so Kyle said, for him, a static posteriorly centered decentered head is one of the most challenging things that he thinks, and one of the biggest unsolved problems in shoulder surgery. He strongly believes there's an overlap between dynamic and static posterior instability. They share very similar common predisposing factors. Some patients have a certain anatomic predisposition for static posterior decentered heads after either minor trauma or even no trauma at all. At this point, there's no clear treatment algorithm, and no surgical procedure has been proven to long-term recenter the humeral head. Having said this, he does talk about his J-span technique, how this theoretically combines the advantage of the bone block plus a posterior wedge opening osteotomy. He uses this for anybody with posterior instability with more than 12 to 15 degrees of retroversion. And in their early experience, they did find that they recentered the head. However, there is a limit, and those with advanced osteoarthritic changes naturally are not candidates for this. But he does think it has some potential, and it's once again an implant-free potential rebuilding the bone stock. He also talks about how in the last 2 years, acromial shape has gained some interest, and there's some potential biomechanical and clinical early evidence suggesting that acromial osteotomy combined with a posterior opening wedge clothing osteotomy might have some theoretical advantage and powerful solution to some of this posterior coverage and reorienting the humeral head, but this has yet to be proven, and surgical education remains quite challenging at this point. So we'll see what the future brings. So Dr. Warner, do you want to give us your thoughts on one of your close friends' article, Dr. Weiser's sort of comments and follow-up studies to that, and kind of your approach to this really challenging patient population?
So fortunately, Gerber's not on this call, so I can tell you what I really think. I think first thing we should take note of is that it's pretty rare in our craft to have the courage to report your bad outcomes. And it's not so easy to get them published either. And you know, it goes to the point that, you know, you can be very useful to people by pointing out what doesn't work. And so this is very important. I also want to go back to an article that I looked at a long time ago that some of you may have also seen by Walsh, looking at this population of individuals. And it's a question, is it the same population? But individuals who have a fixed posterior subluxation with varying degrees of retroversion, nothing that he tried worked. And his conclusion was, this is not a solvable problem. And you know, when you were with me and since, one of the common things that gets shared on the Codman Shoulder Society for difficult cases is fixed posterior subluxation with or without degrees of retroversion. And nobody really has a great solution, although some have, you know, promising results waiting. So nobody's really been able to resolve this issue. And these are very challenging patients, particularly when you get them and you know what their future may be. And in my way of thinking, their future is progressive mismatch of force across the glenoid leading to B2 glenoids and erosion and all the things you know that are going to happen. And what do you do when they're just starting to get those symptoms and they're young and active individuals? And it's in that context, particularly when they come to you in their 20s, more commonly in their 30s. And so I think this is focusing on a difficult problem, and it's one more warning sign for all of us. That said, I was privy to seeing one of the first cases that he's done of his acromion osteotomy, and one of the brilliant observations he's made, and he's made many, is being able to look at the same thing that you and I see every day and see something different that can be corrected. And he recognized that the acromion inclination is different in these individuals who have posterior instability than those who don't. And so his theory is that if you change the inclination through an osteotomy of the acromion, you will also affect the issue of posterior instability. Now, I do not know if it's going to be that way, but I've seen some cases that he's done. Ergo, I started with courage. There's courage as well. And I'm happy he's doing it, and we can see what he does, because I don't want to do that. But that's about all I have to say on it, except that I'm very happy to yield the floor to anybody who has an answer but I don't.
Amazing. Philip, can you comment on that? And thank you very much, Dr. Moore, for those comments. Phil, can you comment? Is your J graph? Is that the answer? Do you ever consider doing the chromial osteotomy? Like, what's your approach to these patients, and do we have any type of promising solutions for it?
So we used to do, back when I was training with Herbert Resch in Salzburg, we also used to do these Scott type osteotomies, and we saw a little bit of improvement in functional outcome, but it wasn't really great, and especially the humeral head remained in the back. So what we figured is that the head wants to stay where it is. And so I believe, and this is also my personal opinion right now, that the J-bone graft is able to have the scapula meet the humeral head where it wants to stay. So we showed in a recent article in the Jesus that in JSCS, sorry, we call it Jesus in Europe, that the scapular neck has an anterior offset in relation to the scapular blade. And this is significant in patients with this pathology. And so we try to adjust the offset of the scapular neck towards the back. But I completely agree with Dr. Warner that there is no solution yet. And this is a difficult topic to handle.
If I can make a comment, Eric, though, I think.
Yeah, I was going to say, Dr. Sanchez, can you give us your sense on bony reconstruction, incorporation, retroversion versus those that just have normal version versus subluxation?
Yeah, two comments. One is that my mentor, Dr. Caulfield, also did a few of these. And one of my partners tried to look at the outcome. And like Dr. Warner said, the paper was never accepted because the outcome was very poor. So I remember Dr. Caulfield telling me, never, ever do a posterior osteotomy of the glenoid. So that emphasizes Dr. His experience. But the other thing is that we're talking about two different types of patients, I think. The patients that have retroversion and pain with no instability, and the patients that have retroversion and pain with instability. And the paper that you're presenting tonight, all patients had instability, not just pain. And in those, I think a posterior bone block does work to take away the instability. It's unpredictable for pain. So I have been impressed with being able to resolve the posterior instability element with iliac crest autograft posteriorly. That's been my experience. Would you agree or disagree with that? JP, Matt, what do you guys think about that?
Can I just make a point, Joaquin?
Yeah.
Some time ago, Gerber made the case that one of the worst prognostic factors for instability is pain preoperatively. And this was in the context of Latarjet. So when you have a population of patients who have instability, but pain is a big factor, it certainly is a warning sign to me that no matter what you do, pain may be a big factor after the surgery, because the best cases, they have episodic pain with their instability and not ongoing pain during their days, when they're just functioning normally.
Yeah, that's what I meant to say, that the indication for a bone graft wouldn't be the painful retroverted glenoid, but the patient that has retroversion and dislocations without constant pain.
Okay.
Yeah, JP, Gerber's article, I think the one you're referring to was after arthroscopic repair failed, if they had pain and went on to a bony procedure for a second, they did very poorly. And I think that theme echoes whether it's posterior or anterior for what he was treating. So I agree. There's no solution for this. I generally do bone graft for those with instability, and whether it's iliac crest or tibia. The bone graft shape here is very different for what we need to use and put back versus anterior. So it's a different realm of thinking. But what's amazing about this article is there was even though he went from 20 degrees to about 3 degrees and probably high-fiving all day long looking at this corrected glenoid version, the static subluxation didn't change whatsoever. And so that was pretty telling and a very important point. And again, like JP said, Walsh just talked about this again and again. Maybe someday we'll figure it out. I think we may be getting there, especially the patients with just instability, but those with pain are down a cascade, as JP said, and Joaquin, of that B1, B2, C glenoid that is a big problem.
Amazing. Wonderful. From Canada, can we quick get your guys' take? Peter Laffner, Peter McDonald, how do you approach these patients? What are your thoughts? Do you have anything to add to what's already been discussed?
Yeah, I just saw one today. So racking my brains out on this 34-year-old guy with the exact same lesion, like a posterior Bankart and posterior glenoid erosion and arthritis, and seemingly no solution. I recently did a total shoulder on a similar guy because nothing else would work. So these are not easy to solve. I wonder, though, if we need to focus on prevention, whether we need to be more aggressive, identifying and treating some of these labral tears early on the posterior side before they get into this downhill slope that it's seemingly it goes beyond repair.
Thanks, Eric. Not much to add. Really great comments all around. A very difficult problem, and I think non-operative treatment is really the mainstay, as everyone said.
Phenomenal. Chris, why don't we move on with 10 minutes left? I want to move on to the last one.
All right, sounds good. The next paper was also in Jesus. So it's titled Capsularaphy with Achilles Allograft, Augmentation for Shoulder Instability in Patients with EDS Syndrome. So this is a multi-center case series, Achilles allograft reconstruction of the anterior capsule in EDS patients with anterior inferior instability or MDI. So 5 shoulders in 4 patients, 3.6 years follow-up. Inclusion was anterior predominant MDI with no bone loss. EDS in type 3 hypermobility. 4 of the 5 shoulders had 1+ prior surgery. They were able to restore shoulder stability in 80%, which was 4 or 5 patients. SANE scores improved, ASES scores improved. Visual analog scores decreased from 7 to 2 at final follow-up. And patients all reported essential decrease in pain medication. The technique consisted of a capsular shift with Achilles reconstruction through a subscap tenotomy. There were 1 patient had recurrent posterior shoulder instability at 1.6 years post-op after injury and underwent posterior capsular augmentation with Achilles allograft. So they conclude that they had great outcomes in a tough patient population. It provides a novel option for anterior predominant MDI and hyperlax patients. And it provides foundation for future comparative or long-term studies and shows promising outcomes of low recurrence compared to other studies. So 2 questions for Dr. Sanchez-Sotelo. 1, can we have your clinic number to send all our patients there? And 2, what did you take away from this study? Is there a role for performing arthroscopic or open capsular shift alone in EDS patients?
Yeah, thank you, Chris. So for the first question, the answer is no. I do see a fair amount of patients with Ehlers-Danlos syndrome. And as you can tell in the paper, there is only 5 patients from 2 different centers. So that gives you an idea that this is very, very selective. I think that in patients with EDS, the psychological aspect of the patients is very important. Many of them are, as we all know, female, and they are very disabled, and that gets them into a cycle, where the family is very worried and so on. So you have to really tease out the possible responders. But the flip side of the coin is that many times they have been told there is nothing we can do, and they have dislocation 100 times a day. And when you get the home run, they are grateful to you for the rest of your life. So I think that's something that we can change as surgeons, where conditions that are supposed to be unfixable, maybe in some patients, are fixable. My rationale for using an allograft is because the collagen fibers of these patients are abnormal by definition. So that's why I've never tried myself to use their own tissue to make them more stable. Maybe others in the call have experience, but my go-to for these patients has been to use allograft for that reason. So I have no experience with doing a primary capsular application, open or arthroscopic, or a Bankart repair.
Jacinta, can you, or Joaquin, can you expand upon selecting that ideal patient for this procedure, both from the EDS standpoint and from the pathologic standpoint?
Yeah, so a few things. Number 1, I never offer this surgery the first time I meet these patients. That's very important. I think you have to, really get to know them well. I try to make sure that patients are psychologically okay, and that the scapular function is not completely off, which, that starts to limit. So if a patient seems to be reasonable, the scapular control is pretty good, and they have laxity everywhere, but they complain mostly of anterior instability, that's the ideal candidate for me. If a patient has true symptomatic MDI where the joint is going all over the place, if they are really affected emotionally, or if the scapula is completely off the chest wall, then I back off. I don't have a magic way to assess it, but that's the way I decide if I dare to do something or not.
And then what about those that have static inferior subluxation? Are you ever, is that a warning sign that it's something you can't solve? Do you think this procedure has some potential for that, or how do you approach those patients?
It depends on the degree, and I don't remember off the top of my head the X-rays of all these patients, but at least one of them had some element of static posterior subluxation, but it wasn't, centimeters apart. It was just a little bit. So I think in those situations, you can still do it. But again, just to make it clear, this is a very small number of patients of the whole spectrum of patients with EDS presenting to clinic.
Eric, can I ask a question of Joaquin?
Oh, yeah, please.
Joaquin, you mentioned something about the scapular dyskinesia that goes along with EDS, and we all see that with all your MDI or EDS patients more specifically. And I often wonder, chicken and the egg, right? Is it that the scapula is moving to try to keep the humeral head from subluxating, is similar to a ball on a seal's nose, and it's trying to get there as the patient raises their arm to avoid the subluxation, in which case it's maybe a protective or adaptive phenomenon, or is that scapular dyskinesia a bad thing like we see? And I often wonder in these patients, should you try to correct that? Will that correct if you stabilize the joint? It sounds like you think it's a bad thing. I'm curious your thoughts on it and the rest of the panel on that scapular dyskinesia we see with MDI. What is that all about?
Yeah, like usual, Grant, that's a great question, and I don't have the answer. I think it's a combination of both for EDS patients. So probably they're trying to find a way to put the scapula in a position in a space that is more stable, but at the same time, their muscles also suffer from connective disease, right? So if I see a patient that statically, the scapula is like way out there, like really stretched out, almost like a trapezius palsy, those really give me pause. If it's more a dynamic thing where they can actually stabilize the scapula if they really pay attention to it, but then the minute they try to move the shoulder, they start to go all over the place, those I think for me are less worrisome. And I know Dr. Warner has a lot of experience with examining the scapula. JP, any points?
Yeah, so with all due respect, I mean, the scapular doctor of the world is Bassam, and he's not here now. He works with me, so he's taught me a lot, at least new terms like STAM, scapulothoracic abnormal motion. But let me go back a ways to the 1980s. We did a study looking at rotator cuff patients and instability patients using Moray topography used in scoliosis to look at patterns of motion, because I had no idea how to look at the scapula. And virtually 100% of people with instability in rotator cuff dysfunction have abnormal scapular mechanics. Now, what's primary, what's secondary? Most of it's secondary. That said, if you stabilize the scapula and it improves their sense of instability, then you know it's a relevant factor. Some of those people, they feel worse when you do that. The only additional point I want to make is that we know for a fact that individuals that lose scapular control, maybe they have a long thoracic nerve palsy, whatever, they can have instability secondarily. And when you stabilize that, their instability goes away. That is not necessarily relevant to the topic here of Ehlers-Danlos, but it's something that's really important. And one of the things we see frequently is that patients will tell you they went to see their different doctors and nobody ever took their shirt off and examined them from the back. And that's really critical when you're evaluating instability, that you look from the front, you look from the back, you look at the scapula, you look at the mechanics, and then you can see what relevance it may have. The only additional point I want to make, Joaquin, is that, and I think, Eric, you asked me a question about this for instability and refractory posterior instability, is there is a population of patients not well described now that have dynamic instability where the latissimus is overactive and pulls the humeral head posteriorly and inferiorly. And for sure, and I haven't written it up yet, releasing the latissimus and lengthening it when you do a posterior capsular shift resolves the dynamic factor here. Again, that's not exactly what we're talking about with Ehlers-Danlos, but it's very important to consider all of these factors with or without Ehlers-Danlos when you try to sort out what's playing a role, scapula or inherent ligamentous laxity or what have you.
Amazing. Dr. Prevention, do you want to jump in?
Yeah, I mean, I could not agree more with, the discussion. Joaquin, thank you for sharing this series of patients. For whatever reason, I have quite a few of these as well. I have not published on them, just like you have not given out your phone number. But it's interesting when you look at the results. I would say my results are right around yours and maybe double the number or something. But what we found, and we started looking at this, and I actually started writing up an abstract, was they had an average of 3.5 surgeries outside the shoulder joint, ankle, hip, other things, elbow. They were mentally tired. Their psychological scores, as you mentioned, were very low and very just had a big challenge to get through that. So we always employed some level of sports psychology, which is usually how I couch it, to get patients to a sports psychologist. You can get back to return to play or do whatever. The preoperative X-rays, when we looked at it, were down about, on average, 3 to 4 millimeters below the joint. And very similar technique to you, Joaquin, collagen, graft. I started first with a tibant weave, but have always reconstructed the CHL as well, the coracohumeral, from basic coracoid to the top of the top of the lesser. So I don't know if that helps, but it's certainly from this inferior subluxation. Many of these patients would complain about just day to day, just their arm holding something. The inferior component of this instability was usually what I found to be their most symptomatic complaint, but one of the ones that is a challenge to deal with. And you go back to JP's work again when he studied the superior glenohumeral ligament, and I think this even goes back to Steve O'Brien, JP, when you looked at that superior glenohumeral ligament versus the inferior capsule, and what's the most important inferior stabilizer, CHL, superior glenohumeral, and capsule. But just like you stated, JP, there's probably multiple factors there. So addressing all of that, do a very similar procedure like you do now, Joaquin, just adding in that CHL. But these patients are very, very, very challenging, no matter what you do. So congrats on a small but really good outcomes in your series.
Eric, could I make a quick comment?
Please.
Yeah, sorry, that's a great study, Joaquin. I've done a number of these as well. I found similar results, but I have found over the long term, I've got one guy who's about 20 years since I did his first one. They do stretch out over time. And I've gone back on one guy multiple times and read data, and he still swears by the operation because he gets about 5-6 years of relief. And he still way rather have that than have a shoulder arthrodesis. But it's something that over time, as the collagen gets replaced and creeps in, that it may stretch out over time.
Amazing. Phillip Morrider, can you give us your perspective on this challenging patient population, how you approach it, or any technical tips or insights into these challenging patients?
I think for me, it's really important to distinguish the actual cause of instability. If it's a true Ehlers-Danlos patient, maybe allograft reinforcement of the capsule is a good option. It seems very promising what Joaquin showed us. So I'm going to send him to the Mayo Clinic as well now. But for me, it's crucial not to label every hyperlax patient that has a very gross type of instability as Ehlers-Danlos patient, because we see this quite frequently in Europe, that these patients are labeled as EDS without any actual diagnosis of a true EDS syndrome. And in these patients, it's more, in my opinion, it's going into Dr. Warner's direction, where you have muscle hypoactivity and muscle hyperactivity. And maybe we need to address this more, because if you put these patients in the OR, even though they showed you a gross type of instability every time they raise their arm, once you put them in anesthesia, under anesthesia, they are actually stable. And this means something in my mind.
That's a great point, Philip, because the patients that I see, if I'm going to consider surgery, they go to a genetist and they get formal gene testing and they go through an independent consultation. I think that's very important. The ones that I don't commit to surgery, sometimes I don't force them, but if I'm going to offer them surgery, I want to know if it's truly a gene-based Ehlers-Danlos. That's a great point.
Amazing. Dr. Sanchez, any other last comments on this challenging patient population?
The only thing is just to emphasize the power of our society, having Philip here. Dr. Charco Alta, who is the fourth author of the paper, happened to be a traveling fellow from CSEC to ASES. In my OR that day, we had that case, just randomly. He went back to the Netherlands and then called me. And he's like, I saw a patient with Ehlers-Danlos, I'm going to do your technique. And that's why it's multi-centers, actually 2 centers. But it gives you the power of ASES and CSEC working together, and having Philip tonight here is great.
Couldn't agree more.
Phenomenal. Any last comments from anybody?
I think that's a great note to end on, Joaquin's comment. Thank you so much for doing this, Eric and Chris, and thanks everybody for joining.
Fantastic. Thank you all for joining us. Have a great night.
Yeah,
Thank
Eric,
you.
Chris,
Good
great
night.
job. Thank you.
Thanks very
Have a great
much.
night. That was fun. Thank you all.
Thanks, Steve. That was awesome. Phillip, get to